Thank you very much for joining us today and welcome to this Education for Health, Closing the Gap in Asthma. As you all know, today is World Asthma Day, so I'm delighted to be doing this this webinar today with a special guest of ours to take you through how we can all support closing the gap in asthma. My name is Preeti Minhas and I'm the Assistant Director of Clinical Learning at Education for Health. So we'll spend the next few moments going through some real themes around what we can do in terms of helping to close the gap. What you will see just before I introduce our guest speaker for today is at the top of your Teams channel, you will see a chat function. So you can place anything you'd like, any comments you would like to insert into those chat functions alongside any questions you may have, or you can raise your hand and then unmute your microphone. If I could ask you to mute your microphone during the course of the webinar, that would be great, just to make sure we've got no interference. And we've also recorded this session as it will be available on our website at a later date for you to review. So that's all the housekeeping, and I'd really like to take this opportunity to welcome our guest for today, Dr. Robin Carr, who's played a role in closing the gap in supporting children and young people's asthma. Welcome, Robin.
Thank you very much, Preeti. It's a pleasure to be here.
So if I could start with, if you could give us a little bit of an introduction about yourself and what you've been up to over the course of the last couple of years.
Last couple of years. Well, I'm a retired GP, and I can already hear people saying, "Oh, wouldn't it be wonderful to retire?" But you will probably find out when you do reach this grand old age that you're actually just as busy, if not busier. But you do have a bit more control over what you do. And I've had a lifelong interest and passion in respiratory medicine, and have had the pleasure of working both in the hospital environment as an associate specialist in respiratory medicine. I was fortunate to be asked to do some things for NICE and the sign guidance to do with asthma. And it was the following on from working with the National Review of Asthma Deaths that fired up my passion to try and do something about childhood asthma in schools. And so that's what I've been doing since I retired, with one of the schools here in Oxfordshire, to see if we could close the gap. And what a day to be presenting it on, World Asthma Day. I'm very, very excited about this.
So you said a little bit about the video that you've been heavily involved in and really striking a passion about it. Talk to me a little bit before we get on to what the video is about. Why did you still feel that this is something that you needed to do in asthma care specifically?
Well, I think that asthma is one of those extraordinary conditions that during the course of my lifetime, we've learned a great deal about it. I certainly know from some of the, I used to love those sort of medieval-like medical lectures where they would show you asthma cigarettes and various different fumes that you could inhale and all sorts of peculiar plants that you could eat to treat your asthma. I mean, asthma's been around for forever. But it's really been in my lifetime that we've learned a great deal more about it. And it's gone from the days where it was looked as though it was something people got a bit asthmatic and because they're a bit anxious, all the way through to actually knowing the pathophysiology, the immunology behind it, the genetic connections. And I suspect we'll get to a stage where people's genomes, not just the fact that they've got eczema, asthma and hay fever, will be much more identified. So we can target the treatment. But the thing that's fired me up was when I first arrived in the West Country, I remember people still talking about a 12-year-old that had died in the town. I mean, it was a town of about 100,000 people, but it was looked upon as being quite rare that a child would die of asthma. And yet here we are, whatever it is, years later, we know so much more. The medication is so much better. And you, your guests, and I, and all of us have been working tirelessly to teach people about asthma, tell people about asthma, help treat about asthma, and yet the deaths from asthma, admissions from asthma, and preventable asthma attacks and deaths continue to happen. And I think that's the issue, is that throughout my whole career, and I'm sure the careers of many of your listeners, will be that we seem to be doing something over and over and over and over again, but it doesn't seem to be having the desired effect. There hasn't been the sudden drop in numbers of people suffering with asthma.
And I think the statistics really show that, don't they? So we still see a huge global figure in those who have asthma. We see a number of, if you look at the UK alone, lots of number of bed days that are allocated to asthma. You know, Gina last year in 2021 reported that, you know, people were using, you know, their medication for half the time, for approximately 50% of their time being adherent to their medicine. So I think, you know, there's still lots to do, and it's really all of our role to help to close this gap that we've got in asthma care.
Looking at the World Asthma page, they have a list of the gaps that they want to close, and practically every single one of those gaps, I think all of us would say, but I do that, and I do that, and I do the other. But the interesting thing is, whatever we're doing doesn't seem to be having the desired effect. I know a friend of mine said that you, of course, Robin, you do know the definition of madness, and apparently this saying was supposed to be Albert Einstein, is to continue to do the same thing over and over again, but expecting to get a different result. And I think there will be a sign of, yeah, tell me about it. We, the royal we, the medical fraternity, have producing, you know, forests of guidelines, huge tomes that we all get given about this is it and that is the other and this is what you've got to do, and some of them are better than others. They're all absolutely spot on accurate, but some of them are impenetrably difficult. And if you were to try and run your asthma clinic with one hand on the asthma guidance and the other on your spirometer, you would see one patient a day. So having guidelines isn't necessarily the whole answer. There must be another way of, as it were, skinning this cat to try and help people to help themselves.
Absolutely. So I guess we've talked a little bit about the recent video that you've done. So talk to us a little bit around what the video is about, because you've got a tremendous amount of views of the video on your YouTube, which is over 13,000, which is absolutely brilliant. So talk to me a little bit more about what the video is about, and I guess why you did it.
Well, there are all sorts of answers to that lovely question. And I think probably that the most important one of which was that I was part of a group of people who felt very passionate about doing something. And there is, I've met people of my age who have said, oh, the youth of today, they're always looking at their phones, they're not interested in anything. But in fact, well, maybe I've met a subsection of young people who are passionate about all sorts of things, from the environment to quite specific things. And so it was when I went to this secondary school called Cherwell School in the centre of Oxford, which is a large state secondary school, and told them about that there were still school-age children dying in this country, that not only were they shocked, but they said, "Well, we that as in the teenagers, we've got to do something about it, haven't we?" And they had a good film club, and they were highly motivated. And I would say that when we started this, I think they were about 16, something like that. And so all these young actors, I remember somebody saying, "Can't you go back and edit some of it?" And I said, "Well, I think some of them are now 3 years older, so it might make the continuity of this particular video a bit difficult." But they were tremendously fired up to try and do something about it. And what could we do? Well, they said that we, as in young people, communicate with their phones, certainly, but on things like YouTube and social media. So if you keep producing documents in the form of a piece of paper, or you stick it on a notice board, then you are immediately going to miss out on your, as it were, target population of people you're trying to reach. And so that was the first and most important reason for choosing this as a different way of saying the same thing. And then the next thing was that I'm sure you, when you've done your clinics, you said to somebody, did you know that you're not taking your inhaler correctly? Or did you know anything about personalized asthma action plans? And there's a sort of vacant look where you say, what's a personalized asthma action plan? Or what's a spacer? And I thought that was the thing that I got rid of when I was a child, sort of conversation. And there is a large, or there are a large number of people who just don't know that there are a number of things that are worth having and worth doing, which are simple, which will modify the way in which they do or take or treat their asthma to such an extent that they are not only better, but they end up inhaling less stuff. And so there was obviously an exercise in trying to tell people, you don't know this, and I would love to be able to tell you about it. And how do you do that? Was over to the kids saying, well, the thing to do, Robin, would be to put all of these messages, which are worth knowing about, into some sort of film, and then we will film it. And so that's what we did. So we've ended up with this sort of public service broadcast type film, which they had. If you were to see the outtakes, I mean, it's practically like a sort of, I don't know, a Disney film where they were goofing about and throwing things at one another. But we edited it down so that there's a lot of really good stuff, but it appeals to people. And when we showed it to people, they said, well, this is great. You get hooked into how Nathan's doing. There is still a bit of goofing about at the end, it just reminds people that these were, so we didn't know, as it were, no teenagers were injured in the making of this film. But what we've ended up with, almost by accident, is something that people want to watch.
So I guess in terms of this film in particular that you've created, it's the Prevent film, which is obviously featured a lot on education for health, and one that we're
Yes.
absolutely supporting with, because as you rightly said, people learn in a different way now. You have to engage with people in a different way, and that's through the advancement of technology and social media. And you've produced this brilliant film around, like I said right at the beginning, which is around closing the gap and supporting healthcare professionals, teachers, close the gap in asthma and really support children and young people with their asthma. So what are the ambitions of this film? What are you hoping to achieve?
Well, that's a very grandiose question, which I will answer, but I just want to catch you very quickly. It's called Preventable, and it's because of the preventable asthma attacks and asthma deaths. Prevent is I think that's the AIDS strapline. So we got ourselves sort of tripped up with the name if we weren't careful. I remember doing lots and lots of talks about personalized asthma action plans, and when I first started sort of throwing up PAAP, most of my audience were thinking that I was going to talk about smears. So the message is that it's preventable. A film about asthma in schools, and that's our strapline. So what are we trying to achieve? Well, if we approach it from the idea that asthma is a chronic, and I use that in its proper medical sense, that it's an illness that you can't cure, it's part of your genes, and it's related to the environment and the aeroallergens that you breathe in. And you may be well some of the time, and you may not be well other periods of time. And for some people, it is described as mild, and for other people, it's described as moderate or severe. And if you look at GINA, you will see that an enormous number of people with mild asthma actually get very, very seriously ill. So I think that if we continue to use those rather outdated phrases, that we may run into some problems. And so if you either have asthma or you don't, and if you have asthma, it's an immunological, allergic, inflammatory condition. And clearly we have put messages about how you prevent that in the film. And so one of my ambitions is that as many people who don't know about asthma get to see it. And so that, as I said, is an enormous challenge. trying to get every asthmatic patient or asthmatic parent to have a look at the film is going to be more than 13,500 views. It's going to be a considerable number. But having said that, schools and youth groups and practice nurses and school nurses and all sorts of environments, Cubs, Brownies, Scouts. Whenever I've gone to schools to talk to them about asthma, the sort of teachers' inset days, the teachers are always delighted to learn a bit about it, because asthma is a tremendously common condition, and they will have lots of kids in their classroom, or lots of kids in their scout group, or lots of kids going camping with them, and they will suddenly find themselves in a position where they're not sure what to do. So you can see how it isn't a case of you and me trying to tell the rest of the country about asthma. It's a case of telling a sufficient number that there are available films and asthma websites and GINA and things like that you can go and look at, and if you make education entertaining enough, then people will watch it. So I want as many people who've got asthma to see it. So that's one ambition. Do, do you want me to carry on?
Yeah, absolutely.
Okay. Well, the other one was, this is clearly aimed at schools, and that is because on the NRAD evidence review group that I was in, it was that schools, although the number of children who died from asthma was very, very small number, practically none of them had had any form of medical intervention ahead of going into hospital. So the first person they saw was the paramedic. And the remark from NRAD was that we could have done something at that stage, and early intervention rather than leaving it to the last minute and then hoping to rescue somebody from respiratory distress or respiratory arrest is much more likely to succeed. A bit like the sort of automated defibrillators, external defibrillators. If you do something very quickly, you're more likely to succeed, and so is the case with asthma. And asthma attacks are actually more common than people having collapses. So if every school had this on their website, if every school had a register of asthmatics so that the teachers knew ahead of hand who had got asthma and who hadn't, and if all those on the register had a copy of their personalised asthma action plan, then I think they would find themselves in a very, very different position to where they are at the moment. And so I see this not as a top-down approach, but as a sort of gradual, almost evolutionary process of showing people that you can do more about asthma for kids in schools, and the schools and the kids and the parents and we as clinicians have got a part to play in that.
I think you're absolutely right. It's about engaging the audience, isn't it? And reaching out to those different audiences. And, sometimes, I get this question asked a lot when we deliver a teaching around conditions such as asthma is, well, how much can I do in 10 minutes? And it's starting to explore all of those routes where we can absolutely use videos such as the one you've produced, and saying to the local school, well, actually, could you put this on your website to really start to educate that local community? And again, it's not something that you just need to do in that 10 minutes. Is thinking about your role. What other avenues have I got to support my local community with it? Well, for their asthma care, essentially.
Yes, I know that one of the questions in the GP exam, which when it first came out was viewed as a bit of a trick question, and it was, what is the most important part of a GP surgery, or the primary healthcare team as it was then known? What is the most important constituent part? And I suspect to the arrogant male GP like me, my answer would have been, well, me, of course. But in fact, as I become older and a great deal more humble, I realize what a small role I have to play in this extraordinary team that we have. And in fact, the most advanced answer is actually, it's our patients. So it's not us as clinicians. We guide, we're part of a partnership with the people who've come to see us, rather than it being this rather patronizing relationship of somebody comes to see me and I hand down tablets of stone from my desk. No, this is a group of people. We're working together with them, and we're looking for solutions which will help with their symptoms. I'm an expert in asthma, they're an expert in their symptoms. And so as a result of which, we make a good team. So part of the solution to how do we distribute this is to ask our patients for their help in distributing it. So you mentioned how we can teach groups of people, and the film that has had actually most numbers of views at the moment is the slightly shorter one, which is the one where we've you can stop and start it. And Mark Levy, who is the medical director of the National Review of Asthma Deaths and is one of the directors on GINA, himself, when I asked him, look, I want to put bullet points into this second shorter one so that we can stop and start it. So there are 3 slides at the end with the take-home messages. So if you are a practice nurse teaching your patients, or if you're a school nurse teaching your teachers, or if you're teaching your GPs as a practice nurse, then you can stop this, having seen the film, and then go through each individual bullet point one at a time, so that you're in a position to say, right, can I take any questions on this? At the same time as sending the film out potentially ahead of your annual review. So you talk about 10 minutes for an annual review. When I did an audit of the respiratory nurses here in Oxford, it ranged between 10 minutes to 30 minutes for an annual review on asthma. And even with those who had half an hour, they still struggled to get in, have we done reversibility? Could I print out a copy of the personalized asthma action plan, etc., etc., etc. And you're left saying, how can I best use this available time? And certainly, if you had something you could send them ahead of your consultation, so a link to the film, because you don't need a sort of CD player, you could just view it on your phone. They can come pre-armed either with having the PAAP that they've downloaded from the Asthma UK, or they can come asking about questions. So I've looked up the website that is suggested in the film, and I saw that I'm not taking my inhaler correctly, or I noticed I don't have a spacer. And then finally, you could also use it in such a way that you then have talked about various things. Rather than using film during the course of the consultation, you could then say to them, well, look, as a follow-up to what we've done, you've now got your PAAP. We've talked about the various different issues to do with your asthma care. I'm going to send you this film, or this link to this film, which will reinforce some of the things that we were talking about.
Great. Thank you so much. I think just while we're having with it's great to see some of our listeners coming on board. Just can I ask you, if you're just joining the meeting, if I could ask you to just put your microphone on mute for me. It just ensures that there's no interference on the recording. You can also switch off your cameras if you feel like you would like to. There is also a chat function at the top, so again you can use that to share any comments or thoughts you have, as well as ask any questions, and we can get to them. So you talked about some of the key home messages, Robin, and it's great to see, having viewed the video, it's certainly so impactful. But we talked about some of the key messages that you'd like people to kind of take home with you. So just going through the key messages from the video, could we just go through that with you, and just making sure that we've got those highlights that you'd like people to take home today?
Sure. These will come as absolutely no surprise. I'm going to look at this piece of paper just so that I don't forget them, because the trouble with being an enthusiast, that you bounce from one thing to another, and if you're not careful, you don't follow things through. And I think Mark Levy's principal message to get across is that all asthmatics should be taking inhaled corticosteroid. I think if there's one take-home message, it's that. Too long all of us, have been managing asthmatics on their symptoms. So if your symptoms go away, then you clearly don't need to take any more medication. And I'm not saying that of any of the experts that you have listening to this call. We are all on the same page that the only way to treat an inflammatory condition is with an anti-inflammatory. But there is a temptation when you have a mum with their little one coming in saying, but I've heard steroids might alter his skin or her skin or change their sex or interfere with their bone growth. And if you're not careful, you and I get seduced into this, the balance of risk of the inhaler versus the balance of risk of not having the inhaler. Now, I've treated asthmatics for long enough to have seen the growth or the long bone growth stunting that you can get in some very poorly controlled asthmatics, and it is a disaster. And I remember with huge pride and absolute joy, after being in Yeovil for 20 odd years, one of these great big tall strapping young severe asthmatics wandering as a sort of gangly teenager into my consulting room, and I thought, got it, that we've actually succeeded here. What a beautiful creature you are as a result of you being treated appropriately. So inhaled corticosteroids make a difference. And why you can develop a relationship with the parents when they're young about appropriate inhale technique is that if you're using a spacer, then more of the finer aerosolized particles actually get to the right place. So rather than you having shed loads of inhaled steroids that are all on the back of your throat that you then swallow, you're actually getting the 5 micron size particles to the right sort of place, which means that you can control your asthmatics with a much smaller amount of inhaled steroids. So I think the inhaled corticosteroid message is top, front and central.
Just before you continue, Robin, can I just ask everybody to mute their microphones, if that's okay? And again, if you do want to say anything or comment, you can use the hand at the top or the chat function. It just ensures that we keep any interruptions to a minimum. Noise interruptions, that is. So sorry. Yeah.
Oh, that's absolutely fine. So second in the queue is that relievers, so short-acting beta-agonists, are only for emergency use. And all of us will know that we have people who practically live on SABAs. There is now evidence that the use of short-acting beta-agonists actually increases the chances of getting an acute exacerbation of asthma. I am not bright enough or can understand the evidence around that, because is it because they've got poorly controlled asthma that they're using a lot of short-acting beta-agonist, or is it because they're using a lot of short-acting beta-agonist that they've got poorly controlled asthma? I don't know, but the one thing is absolutely certain is that if you're using more than 12 inhalers a year, that you are absolutely on the waiting list to be put straight into hospital with an acute asthma attack. If you do have the chance to talk to somebody and say, well, why is it that you're doing this? Sometimes the answer is, well, I can't afford more than the one inhaler. And now that it's practically a sort of king's ransom to go and get your prescription filled, if you've got a short-acting beta agonist, a spacer device, a long-acting whatever, and if you're not careful, people will cherry pick from your prescription as to the particular device they want. But sometimes it is because they're scared of inhaled steroids. And so some of those myths that surround the inhalers are things that if you address that, and it makes me sound as though I know and you don't, far from the truth. The weight of intelligent people in the room at the moment, I feel quite humbled but by the fact that all this collective knowledge, it just my experience, I say, that people just don't know or don't understand sometimes.
And I think it's really important that, we talk about that belief, isn't it? Because everybody's, everybody's got a different reason as to why, they don't want all medications on their prescriptions, and it's really about we need to engage every person differently, because everybody's views are going to be differently and everybody's beliefs are going to be different, and that may be based on their religious views, it may be cultural views, it may be, your mum and dad's views. It's all very much, it's very different. So I think that's a really important point that you made, Robin, about we do need to make sure that we engage with patients and understand their beliefs to then be able to give them the information they need to take home with them and help to make that informed decision about their health.
Thank you for making the point about religious views, because one of the I moved from the West Country to central Oxford, effectively, and for the first time came across some of the difficulties that managing a multicultural population of asthmatics then presents. And I was privileged to be part of a process that translated the Asthma UK's personalised asthma action plans into 10 different languages that we had here in Oxfordshire, and had tremendous fun talking to lots of people in their own. Well, they were given Gujarati or Bengali or Mandarin versions, and they showed me how we had translated it incorrectly. So I think we have a rich, diverse group of individuals who can all benefit from getting the most cutting edge asthma advice, so long as they get the information in the right language. So the PAAPs are available in many different languages. The film is currently in English at the moment, but you have a subtitle bit at the bottom, and we are keeping an eye on how many people view it, and if there is a sufficient desire to have, a different translated. We obviously can't change the kids talking in English, but we can change what's in the subtitles. So maybe it would be of use to change it into different languages. I don't know, but it's sticking with the culture. I didn't know that some people didn't take inhalers during Ramadan, for instance, and went to go and speak to the imam at the JR, who said actually it's perfectly okay to take inhalers during Ramadan. But so I've been able to say that with authority, that an expert leader in Islam has been able to say it's perfectly okay to do that. But those sort of cultural things then present an extra layer of difficulty that the nursing staff who you teach, and the doctors, because I'm an education for health pupil of yours as well, will know in spades. It's not a one size fits all, and so therefore our extraordinary country has a whole wealth of different people who will speak lots of different languages other than English, and have cultures that don't fit in with the medicines that we give them, and we have to work with them, because the asthma is quite happy to affect anybody, creature or culture or creed.
No, absolutely. So I think we have a message from a listener. So I think we have quite a few people that have joined us. So thank you again for listening to us today on this World Asthma Day. Can you just remind us of the name of the short video you've produced, Robin?
So if you put into either Google or YouTube, Preventable, and then full stop, and either a film about asthma. We'll take you. Sorry, I can't hear you then. Go to the party that's at wherever that one is. Sorry, so if you put preventable and then full stop and a film about asthma in schools, it will take you to either both of them or one of the films, and that the longer of the films, which is 14 minutes, is aimed at everybody, and it is the one that I would recommend is seen and posted in schools. All of these films have been made in such a way that they can be shared on social media. And it has all the messages in it, but they don't come up as slides. If you put preventable full stop a short film about asthma in schools, you'll get taken to the 11-minute version, which has in it, we've foreshortened it so that you could then stop and start it. And after the kids have done their filming bit, you then have the slides with the take-home messages on it. So that if, let's say, that you're in a teaching session, you can stop it and say, right, let's talk about ICS or reliever inhalers or patients needing personalized asthma action plans. And then you, because you can pause and start again these YouTube videos. So that's what it is. So the word is preventable, either a short film about asthma in schools or a film about asthma in school.
Brilliant. So we were talking about the key key messages from the video. One you mentioned around the ICS, the inhaled corticosteroids, obviously relievers being for emergency use. What are the other kind of key messages you would like people to take away from this short video?
Well, we could talk until the cows come home about personalised asthma action plans. Interestingly enough, practically every single NICE guidance, sign guidance, and I mean, you could go back as far as you like into the sort of 70s, 60s and 70s. People have been talking about written asthma action plans. And the evidence that has amounted over the years that shows that they make a huge difference, not only to people's relief from symptoms, but also they reduce healthcare utilization. So the economists amongst us will all be pleased, but also that they save people's lives, because if you're not having an asthma attack, then you're less likely to die as a result of your asthma. And if you have got a BAAP, it will tell you what to do when you're having an asthma attack, and more importantly, will tell you what to do if you're starting to become unwell, and then what to do in that event. And each person is different. So printing it off the internet, and I would still steer you all towards the Asthma UK's website, where they have all these resources in different languages as well. But it has to be personalized to you, so that if you've got a particular inhaler, it may mean that you increase the dose considerably. But if you're already on high dose or medium to high dose inhaled corticosteroids, it may be that you actually start on oral steroids, or it may be if you've got brittle asthma and you've had multiple admissions to hospital, the answer is not to mess about with anything at home, but you dial 999 because the last time you were you had to be ventilated, and so on. And so each of those PAAPs has to be individualized to a particular person. So that is one of the take-home messages. In this country, about 30% of asthmatics have a PAAP. I don't know how Northern Ireland have managed to have 60% of their population of asthmatics have PAAPs, and how in Oxfordshire we only have 23% of our population have PAAPs. And it's got nothing to do with bad doctors or bad nurses, and everything to do, I think it's just a cultural, or it's just not something that people do. I mean, if you ask a diabetic if they keep their blood sugars, they would say yes, of course I do. If you ask somebody who's taking warfarin, do you know what your INR is, they say, well, of course I do. And so for other chronic conditions, I think the PAAP is a little bit about denial. So if I don't have it, maybe I don't have asthma, and a little bit about, okay, it's a bit clunky having a piece of paper, but a piece of paper is better than not having anything at all. You can get these things that you could have on your phone. But if you've got a piece of paper or you've got a copy of it, it could be at school so that someone else, when you're not very well, can look at it. And the key thing is that if you're becoming unwell, it will then not only give you the permission to do something, because I think my experience, and I'm not sure if it's the same with you, is that people are terrified about doing something too early and wasting everybody's time, and then end up being told off for coming too late because they didn't get in touch soon enough. And so your poor darlings can't actually get it right either way. But if they've got a written management plan, they will follow it. And then if it says, and if that doesn't get better, please phone 999 or phone me or phone somebody. Phone. But this idea that it gives you more than permission to, I think he said double the inhaler, or did he say treble the, or was it quadruple the inhaler? Because it used to be double and is now quadruple, or, oh, I don't know what to do. I'll just go to A&E. So you can see how having it written down, it makes it a whole heap easier to follow and gives you permission to do it.
Absolutely. And I think it's about those family members, those carers, those school teachers, making sure they know where a copy of that personalised asthma action plan is, because actually when somebody's struggling to breathe, it's very difficult for them to point that individual in the right direction.
The other thing about it, obviously it's your PAAP, but other people may look at it, is that I wonder if sometimes that people are slightly fearful of chronic illness. I know that in one of the things that I did with the Cochrane Airways group, we looked at what happened if schools or members of schools were educated about asthma on their peers, and some of the health myths around asthma amongst other school children. And one of which that stuck in my mind was that that it was thought that asthma was contagious. Somehow you might catch asthma from someone, and you could see how that might work, because if you had a cold and your asthmatic friend had a cold, your asthmatic friend got very significantly worse from their asthma, and you might be thinking, oh crumbs, if I sit too close to him in class, then maybe I will get that as a result of this contagious illness. Whereas once you started to increase the amount of education and remove the bogeyman, as it were, from the health myths surrounding that, what the schools were then able to do was have a great deal more peer support rather than peer abandonment. So you would find kids would say, well, excuse me, sir, I think my friend's feeling, he's coughing round the back of the changing rooms. I'm not sure if he's terribly well. You wouldn't mind taking a look. And that then was in the same way that if somebody had tripped over and had bashed their head and were bleeding, that you'd rush round and help. That the other school kids felt that they could intervene, particularly if it was written on the little personalised asthma action plan.
Yes, no, absolutely. And I think we've got some comments around the importance of personalised asthma action plans, and also the importance of them being reviewed as well. Just going on to, we've talked obviously about the key home messages. So one we talked at length, didn't we, Robin, was around inhaler technique being checked.
Yes. Yes, and that is another one on the list you will find when you get a chance to look at the film. So inhaler technique, a dear friend, Jo Riley, one of the sort of nurse consultants here in Oxfordshire, she and I used to collect spectacular examples of bad inhaler technique, and I'm sure many of your guests in a quiet sort of chuckle to themselves when they discover some of the inhaler techniques that we, either GPs or people, have learnt by accident. I still think one of my favourites was one of my patients who used to squirt their inhaler onto their pillow at night because they only felt short of breath when they went to bed. And you go, well, who on earth taught you that? And you think, well, maybe it's my desperately poor communication skills that had led to people misunderstanding how to take it. Or there was a professor of respiratory medicine who said, embarrassingly, that he discovered one of his patients who turned their head to one side to take their inhaler, because that is what he had demonstrated in the clinic, and ended up firing the inhaler behind their ears. And I think YouTube has a whole load of fairly spectacularly ghastly forms of how not to take your inhaler, famous actors and actresses doing thus far. I think the alarming thing is that I think you told me it's more than 50% of people who don't take their inhalers correctly. Is that right? I thought it was actually more than that, more like 80% of people don't take their inhalers correctly, but it's a gigantic number of people.
Yeah, so we said Ingenia reported last year that at 50% of in 2021 they reported that it's adherent for at least 50% on their medicines to inhalers.
Yeah, and that word inherent is one of those wonderfully obscure medical terms, because I think if I said adherent to my children, they would wonder. It would be about sticking plasters sticking to their skin being adherent. But when we talk about inherent, it is, are you taking this particular medication in the fashion at which it was prescribed? And certainly you can have a problem with not taking it 3 times a day or twice a day or once a day, or you are not taking it correctly, or you're not following any of the other various different aspects that will involve this medicine getting to the right place. And you could understand that if you are, busy mum with 3 kids, trying to get them, what do you mean you've lost your homework, or you haven't got a sock? And to then get the inhaler technique right for all of them, all at the same time before they go to school. So you could see how, if we make things complicated enough, then inhaler technique just goes out the window. I certainly know, and because I remember telling you a story about a family where they had 3 boys who were all atopic. And it was only when I discovered that I had made their inhaler techniques, or all their inhalers were all different. Why don't you take this one's got to have it, you shake this through the spacer and it has 2 puffs twice a day, and this one has 1 puff of a dry powder device once a day, and then there's another one that having it at different times a day, and you're left. I could not have made it more complicated for this poor mum and her children. Surprise, surprise, the kids were bouncing in and out of the A&E department to my GP surgery. And so we have a part to play in this, and certainly part of it is to make it, I remember someone telling me it's the patient chooses the inhaler rather than the doctor choosing the inhaler. And if we had the most glorious opportunity to spend ages and ages and ages with people talking about inhalers, you would see people turning them over and say, well, can I try that one? And they would find they had the right sort of inhaler technique and the inhalation power for a particular spacer, a particular inhaler device. And you say, well, okay, well, we'll go down that avenue. But if we make it the regime too complicated, then they can't take it. And then you're absolutely right. It needs to be reinforced. I mean, as a pharmacist, you would tell me that that's what you do for a pastime, isn't it?
Absolutely, and it's that reinforcing. It's a bit like driving a car, isn't it? Sometimes you develop some incorrect habits, should we say, when you learn to drive a car. So that inhaler technique it's not just important at the beginning of when somebody's being diagnosed with the conditions, but all the way through their treatment. And there are multiple devices out there as well. So again, it's really important that we educate people around the inhaler techniques. And absolutely, as the COVID pandemic has taught us a lot of, there's a lot of inhaler technique demonstration videos that are now online. So what we've seen is some healthcare professionals, prior to a patient coming to their consultation with them, is actually sending those videos out to be able to say, look, make sure you have a look at this and see how your technique is against this. So again, I think the COVID-19 pandemic has, really supported in helping educate patients. And again, there's websites such as the Right Breathe app, if I get my teeth in today, which really is useful to making that difference. So apologies, I know there's a couple of comments that I'm getting through as quickly as I can.
I'm
And just
glad you're doing them.
so in terms of, we talked a lot about the kind of preventing the asthma attack, but what happens when an asthma attack does happen, Robin? Because I guess that really tells us that there's something that's gone wrong.
Absolutely, and I will answer that question in sort of two halves. So clearly, that the management of an acute asthma attack is based on the acuteness of the attack. So the if you have somebody who's in extremis, there is clearly a sort of recognised management protocol to go through. Which I think we could spend an entire podcast talking about how you manage an acute asthma attack. So I won't actually do that immediately. I think what I would like to do is, if we stick with, so someone's having an acute asthma attack at home, because that's where these things start. Mercifully, people don't tend to pitch up in the surgery and then have an asthma attack whilst they're waiting to see you. They are often at home, having tried something, having got worse, and then decided that they were going to come and see you. So the management of an exacerbation starts well before they see you, and so hopefully they will have followed through some of the things that you had taught them. And so, turning to the back of the personalised asthma action plan, it has in there, what do I do if I'm starting to become unwell? And clearly, for some people, you would ask them to fast forward to that page very quickly. Some people will use peak flow devices and will have carefully, accurately, and methodically measured their peak flows and said, well, actually, this is very significantly less than it should be, and so therefore I'm going to carry out those instructions. But for many others, they're basing it on symptoms, and they're going, I don't like the feeling of this. This feels just like the asthma attack I've had before. And so symptoms or signs, the more objective signs aside, you would encourage somebody to start by taking the 10 puffs, one every couple of seconds. I've got myself muddled now. It's not every second.
We'll put the asthma guidelines
Yes,
into the chat. So it's every 30 to, between each dose, it's 30 to 60 seconds waiting between each dose.
Yes. So there's a pharmacological element to this, which is the inhaled short-acting beta agonist, but there's also the other physical parts to it, and that is encouraging people to sit down rather than lie down, sitting them up straight rather than having them hunched over, just simply because the mechanical problems that you create with the lungs by either lying down or by huddled over mean that you're adding to the problems. Being confident in what you're doing can reduce the level of anxiety, and asthma and shortness of breath. The one thing I remember being told when I was a baby doctor, which was, no matter how anxious you feel, whatever you do, don't convey that anxiety to your patients, because anxiety is contagious. And if you want to sort of adopt, as most practice nurses do for a pastime anyway, the sort of swan syndrome, graceful on the surface and pedaling like hell underneath the water. And so you want to try and do your pedaling discreetly as you're managing somebody with asthma. And certainly there is a temptation to think that the only way of managing an asthma attack is with a nebulizer. And then you suddenly find yourself as a rural asthma nurse who's gone out to go and see somebody, and how on earth do you plug something in if they're in the middle of a nowhere or in a campsite? And both NICE and SIGN and GINA have all shown that you can actually manage acute exacerbations of asthma very effectively with a spacer and a metered-dose inhaler. So the first steps will be to follow what's in the personalized asthma action plan using a short-acting beta agonist, and then almost as importantly is, if you're failing to improve, that you get in touch early, because if you remember from your sort of physiological days, sort of oxygen dissociation curve is pretty steep. So by the time an asthmatic is exhausted, you have very little time left in which to intervene, where they will then start to become hypoxic. So if you've got a hypoxic asthmatic, you are towards the end of your opportunities to intervene. So, I mean, we're drifting too far, I think, into the management of the acute asthma attack. But what you want to do is to catch them much, much earlier on. And clearly, some of that is to engage them with, this is what I want you to do, and this is what I want you to do if it isn't working. So that part.
Great. So I guess we have shared the link into the chat, so anybody that would like to view or use the video to support supporting and closing the gap in asthma care. But I guess leaving our one thought of the day, or a couple of thoughts, is how would you want healthcare professionals to use the video that you've produced? I know we've briefly touched on that throughout this webinar.
Can I very, very quickly, because I'm looking at the time, just say that Mark Levy will give me a thorough ticking off unless I tell you the rest of the bit about the asthma attack. So I think it's important to realise that something has gone wrong if somebody has had an asthma attack. So we are trying to engineer a situation that they don't. So if somebody had an asthma attack and they're now coming to see you, I had an asthma attack, I went to the hospital, went today, what went wrong? And there, in the sort of shorter version, there are 4 key questions that are worth asking and following through. So, is the attack over? So someone will come and see you and say, "Oh, I'm feeling much better now," but you do their peak flow, or if you do their exhaled nitric oxide, and you will find that asthma attacks don't stop suddenly. The immunological cascade continues for some time afterwards. So is it over? Are we stopping the steroids? Are we stopping the enhanced treatment too early? What actually went wrong? Was it that they stopped an inhaler that they were taking? Did they go from taking a spacer to not taking a spacer? Did they pick up a flu-like illness or worse, like COVID? And what do I need to change? Was there something about the inhaler device that I chose that was hopeless, or the regime that was hopeless, or that they were frightened about doing something? What are the modifiable risk factors that need fixing? So those would be the things that are worth going through when you see somebody after an asthma attack. And to answer your question, what would be my final take-home message? Well, look at it, and then if you like it, share it. I mean, the more people who see a film, the better. The more questions it generates, and if what it does is that it creates a group of people, our patients, whether they be in school or on our patient lists, that become more curious and want to learn more about their condition so that they can manage it, then I think we've succeeded. Because the one thing is absolutely certain is that we are something like 100,000 nurses too few. There are thousands too few doctors. There aren't enough doctors, nurses, and healthcare professionals available to look after all our chronic diseases. And so we have to turn to our wonderful patients and say, look, we're going to have to teach you how to do this so that you come to me when you don't know what to do, and together we'll keep this illness under control. So share it. That would be my take-home message.
Brilliant. Well, that brings us to the end of today's webinar. I know there's some comments and questions. Certainly for the questions we weren't able to get to today, we will produce a fact sheet which will get uploaded to the website to support you with some of those questions. I'd like to thank Robin for today and joining us and talking through the Preventable video and your role that you've played, and significantly the number of views I think is a real credit to the work you and your team have done around supporting closing the gap in asthma care. We also have a number of additional resources to support you. So if you go onto our website, which is www.educationforhealth.org, you will see, like I said, a number of resources that you can use for yourself, but also your team as well. So we have things like the Winter Respiratory Pack, which is a number of fact sheets around different topic areas, including greener respiratory care and also the use of spacers. And we will also be having the supporting children and young persons e-learning as well, which again will be a free resource that will be available to all learners. Again, this webinar is recorded, so it will be uploaded to our website for those of you that have joined recently. I'd like to thank you all again for joining us today, and a special thanks to our guest, Robin. Thank you very much, and thank you for today.
Good luck. I mean, my part in this is to wish you well. It's been an absolute pleasure. I'm retired. It has been an absolute joy, privilege to have worked with so many amazing respiratory nurses. Good luck. I'm going to keep doing my bit.
Thank you so much, Robin.